Ms Hands.
Good morning, my lady. We'll be starting with Miss Julie Parkinson this morning.
If you could repeat after me, please.
I do solemnly,
Sincerely and truly,
declare and affirm
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Ms Parkinson, good morning. You are attending the inquiry today to provide your experiences of running a domiciliary care agency during the pandemic. Is that right?
Yes, that's right.
And you have provided a statement to those following. It can be found at INQ 000614375. By way of background, Ms Parkinson, is it right that you have worked in the care sector for approximately 20 years?
That's correct.
And that's in both care homes and in domiciliary care?
Yes.
And then in 2007, you set up your own domiciliary care agency?
Yes, that's correct.
And you have said in your statement that you've held the role of manager, but you also have qualifications and training to provide care to clients if required.
Absolutely, I'm a trained carer.
And in relation to the staff and services within the agency, is it right that you had 15 employees and 23 clients during the pandemic?
That'd be correct, yes.
And they were all vulnerable adults with different complex needs, aged between 18 and 101 years old.
Yes, that's right. Yes.
You have also described how in a typical day, one of your employees might visit between 5 to 6 clients, sometimes up to 4 times a day during the day and night, and will provide support with tasks such as personal care, medication and welfare checks.
Yes, that's correct.
And if a client requires it, they will also work in pairs, is that right?
Yes, some calls would be for a single carer, and some calls would need two people for moving and handling.
And I'd like to turn now to your experiences of running the agency during the pandemic. But before I do so, could you briefly summarise how you and your employees felt at the very start, in perhaps February, March of 2020?
Yes, at the beginning of the pandemic, there was a lot of fear. We didn't really know, nobody knew what was out there and what was going to happen. So there was a lot of fear, and we talked to the staff and asked them whether they wanted to continue working. All of them wanted to continue. Their question would be, well, who would look after our clients if we didn't do that? So they had already made that decision that they were going to continue. We did have an instance where the confidence was undermined, and that was by some paramedic staff. Gave some information which undermined the confidence, and 2 members of staff left because of that. But we discussed that with the rest of the team and said, if you need to leave because you've got problems, if you've got a baby or you live with your grandparents and you're worried, we understand, and we'll manage. And we did.
And you've said in your statement how you try to ensure that your clients will see the same care professionals every day. Why is that important for your clients and staff?
Oh, for continuity. The staff get to know the client, what their wants and needs are. That's set out in the care plan. But it's getting to know them individually, and the way they like things done, and that's very important to people, and to keep their routine the same. So it's important for the staff to have that connection. And from the client's point of view, it's important for them to see the same people. What they don't want to see is a different face at the door every day. And in some providers, they have such huge teams that they have different people going in all the time. They can't make a personal connection.
And was it always possible to maintain that during the pandemic?
Absolutely, yes. Our teams worked in the same teams that they always did, and I supplemented the staff, so I knew everyone everywhere as well.
And did your staff continue to visit between 5 to 6 clients per day, or was there any reduction or restriction on their movement?
Yeah, right at the beginning, when we weren't sure what was happening, we did look at which calls that we could reduce either or move to a telephone appointment. So we would ring and say, do you need us to come for the next call? That was to minimise contact, because that was the important thing at the time in lockdown. It was minimising contact, so we did do that. It wasn't for a very long period. It wasn't just until we were confident in what we were doing and how we were going to do that, and then the normal service resumed.
And were they telephone calls or were they video calls?
Telephone. Yeah.
And did your staff and clients have the technical ability to do with that? And to
Yes,
engage with that?
we only did that with people that we knew that they could possibly manage a little bit longer until we got to their next call.
You have explained in your statement how some of your care workers were required to carry out more healthcare tasks than usually required of them. Can you provide some examples of the type of tasks that they were carrying out?
I think mainly that was wound care. If you've got someone with pressure sores and they've got dressings, normally we would never have dealt with dressings prior to the pandemic. And that's about infection control and obviously wound care. But we do that now as a result of the pandemic, because obviously the nursing teams were limited as well. So they left us enough supplies that we could carry that out. And obviously if we found signs of infection or it was deteriorating, then we would definitely get the nurses involved. But on the whole, we were able to manage that and help them, because then that saved them their time to deal with other calls.
And you said that that's continuing.
Yes.
Why do you think that is?
I think it just helps the nursing, the community nurses, so they know that we can do that safely, and that if we feel as though we need help, we will ask for it.
And did you or your staff receive any training on those tasks?
Brief training.
Sorry.
Brief. It was brief training.
Can you remember when that was?
I couldn't say specifically. It would have been particular. It wouldn't have been general. It would have been specific to an individual person with wounds. So we would have been shown, well, by the nurses, this is what we want you to do, and this is how to do it. And then, so that would just apply to that one person.
Do you think it would have been helpful if there had been more training?
I think it would be, yes. I think we could. That's something that could happen, yes.
Who do you think would be best placed to provide that training to you or your staff?
Well, again, I think there is generic training. We can do e-learning on that sort of on tasks, but we would appreciate specific training to that individual, because everyone's different. So each person would need a different level of care. So the training is specific to that individual. That's person-centred.
And did your care workers have any problems in accessing medical care or treatment for your clients if they did need it during the pandemic?
That was so difficult. It really was. It was the GP service. They were in disarray as well, with shortage of staff, and obviously they were overwhelmed with people who thought they had COVID or might have had COVID. So it was very, very difficult to get doctors' attention. We were recommended to use 111 service, and that doesn't work in domiciliary care because you've got to stay with the person that needs the help to answer the questions. It just doesn't work. So we had problems getting appointments, getting doctors to come and visit. People who are bedbound and can't go anywhere. So the call times, we'd be on hold for up to 45 minutes just trying to get through to the surgery. And we would have very, very robust conversations with receptionists to try and get care.
Did you observe any impact on your patients as a result of that?
Well, we achieved our aims. We always got the care. It was just an extra burden for us to have to really fight for that.
You've discussed in your statement the IPC guidance that was issued, and you've stated that you felt the guidance was tailored more towards care homes rather than domiciliary care, and was often not appropriate or even relevant to the services you were providing. Can you provide any examples of those type of measures that were in the guidance that didn't readily fit within the domiciliary care setting?
Yes, we in domiciliary care, we have infection control procedures, and we used PPE. We had a stock of PPE because we always did. I think that we were already working to those standards, and suddenly we were getting new information that we had to do something differently, with different instructions for donning and doffing PPE, which wasn't appropriate to domiciliary care. There was videos and posters giving information on how to do that. Always, the instruction would come from someone in a clinical outfit, in a clinical environment, in a special room to one side in order to don and doff your PPE, with a clinical waste bin next to you that's foot operated, and then you would drop it into the bin. And that just doesn't work in domiciliary care. You just don't have that environment.
What is the environment for donning?
Well, it's very different. If you think of the house that you live in, all the houses that we went to, they're all very different. Some of them are very, very tiny, and you're just standing in the doorway, putting on your PPE in the doorway. Sometimes you could go into the bathroom to do it, but not always. And certainly during COVID, you would put that on right at the beginning. You wouldn't want to go into the house in order to do that. You would do that at the door. You didn't have the waste disposal. You just had someone's kitchen bin or their waste bin outside. So that, we didn't have clinical waste. So that didn't really work for us. We just had to continue doing what we always did.
And do you think it would have been helpful to have had specific guidance for domiciliary care that perhaps would have taken into account some of those?
Well, just if they'd acknowledged that it would be different for us.
Yeah.
There's no acknowledgement.
And did you, as a manager of a provider, receive any support, or were there any resources available to you to help interpret and disseminate the guidance to your staff?
Well, at the time, I think it's slightly different now, but at the time, I felt completely isolated. As a manager, I'm self-employed and run my own business. I don't have a team of admin staff. I don't have anyone really to talk to. And at the time, it was just me receiving all of the guidelines coming from different, some from the local authority, some from Skills for Care, some different bodies sending information, and I would have to pick my way through it all and find and interpret it to our service, because it was clearly a lot of it was meant for health and a lot of it was meant for care homes, and I had to pick out the bits that would be appropriate to us. And I didn't have anyone to discuss that with. And I did ask for help. I think it was probably from the local authority, and they said, "Oh, we've sent you all the guidelines that we've got." So they did their job, but then I had to just work with it myself. So I just had to do what was best for my service.
And how would you inform your staff if there were updates to the guidance?
Well, we have a group chat, a network where we can disseminate information, and by telephone. And obviously I was out on the road working with them as well. So
group
face to
chat
face.
between
Just the staff internally.
just staff, so not other people in a similar...
No, just the staff. So a way for me to communicate with my staff.
And on the same topic of guidance, but looking at it perhaps from the perspective of those that you were caring for, was it suitable for their diverse needs?
Sorry, say that again?
The IPC guidance or any
Right.
of the national guidance that you were asked to follow, was it suitable for the needs of those that you were caring for? The PPE
I think
guidance?
so,
Yeah.
yes. I mean, infection control was for everyone, wasn't it? Suddenly, it wasn't just the people that we were caring for, it was for ourselves as well, and for everyone in the community. So I think it was right to have infection control. But there was social distancing as well, and we couldn't do that. And we were working together with an individual, hands-on. You couldn't be 2 metres apart. So we needed PPE for that.
And you've said in your statement that you attribute the confusing and impractical guidance from DHSC to the fact that they lack knowledge and understanding of the sector and do not listen to recommendations coming from the sector. How do you think the sector can be better understood and listened to in future?
I think just need to really recognise that it's different. We're sort of all swept. The Department of Health and Social Care sweeps everything together, and it includes health, includes social care. Social care is so vast in itself. It's care homes, it's domiciliary care, it's family care, unpaid carers, it's supported living, it's mental health support. It's so different and vast. I wouldn't like to have to put a policy together that encompasses everyone, but I think just acknowledging the differences and really focusing in on how we work and how different it is for us and it being in a clinical environment, yes.
Sorry for speaking over you. Is there a role, do you think, for consultation with stakeholders and service users?
Without a doubt.
I just want to ask you about the topic of funding and whether you or your employees tried to access any of the additional funding that was made available during the pandemic.
We didn't.
Was there a discussion or reason for deciding not to try to access it?
I think it was just a complex. It was new. It was brought in just right in the middle at the height of the pandemic when we were all just sort of just trying to keep it together. And I think it was more geared towards care homes as well because they had different problems to us. And they needed, extra cleaning or their staff they had a lot worse staff shortages, and I think it wasn't really going to help us in any way.
Was there any financial impact on your workers or the agency as a whole as a result of having to self-isolate or the shortages of staff?
No, I think we didn't actually have, in the first lockdown, we didn't have any member of staff self-isolating, so it wasn't a big problem. Certainly later on we did have staff that did actually contract COVID, but I think I'm not really sure because our payroll is outsourced, so I think they might have.
And you have told the inquiry that you didn't introduce the mandatory vaccination during the pandemic, as most of your staff had received it once the condition of deployment had been brought in.
We all had the vaccination when it first came out. We all had that vaccination. Everyone had it. Our local authority was really good. They organised stations and gave us time slots for our staff. So all of our staff had the first vaccination and then the booster. It was about 3 or 4 months later there was a boost. So every single member of our staff had that. Nobody wanted to pass the virus on to one of their clients or to a member of their family. Nobody wanted to do that. So everybody had that at the beginning. Later, when it was 6 months later and the second wave of vaccinations, there was a lot more scepticism. And we were a lot more confidence, I think, because they'd had the first vaccination and felt as though they were safe. And there was a lot of negative publicity around the vaccination, and a lot of the girls felt as though they didn't need it and didn't want it. Then the government said it became a condition of employment, and that changed everything again. All of my staff, well, most of the staff took it under that circumstance that they needed to have it in order to continue working and looking after their clients. So they did. Of course, right at the last minute, when the NHS really objected and didn't, and obviously the government realised they couldn't actually enforce that as a rule, and that rule then changed, that really upset a lot of staff because they'd obviously taken the vaccination and they didn't actually need to, so they weren't happy about that at all.
And you briefly referred to the fact that you had some PPE stock going into the pandemic. Did that include a range of different types of PPE, masks, for example, hand gel?
No, prior to the pandemic, we didn't use masks in domiciliary care. We used aprons, disposable aprons, disposable gloves. All the staff wear tunics, a uniform, but then they would have their plastic apron on when they were delivering personal care, and gloves. So we had a stock of that because we use that in our normal practice. We didn't have masks, and right at the beginning there was conflicting information about masks. There was talk of everyone was having masks, but we couldn't get them. And we did buy some. There was people making cloth masks on Etsy and, that sort of thing. So we did buy some masks at the beginning. And then once the portal opened and we were given them, then we used them according to the guidelines as best we could.
Was that reliable?
Actually, we did have hand sanitizer gel as well. We used that as well as part of our own infection control. So we did have a supply of that, but it very quickly ran out because I think a lot of it just disappeared off into families taking, thinking, oh, well, that'll be useful. And I didn't mind that at all. I just wanted everyone to feel safe, but we did run out of hand sanitizing gel, and that was very concerning.
Can you recall how long it was before you were able to source more hand gel?
I wouldn't like to say how long that was.
You said that you were able to access the PPE portal. I think that was from around May 2020, you've said in your statement. Was the PPE that was available through that reliable in terms of delivery and the type of PPE that was actually then delivered?
It was. It was very useful. It was the same products that we had already been using, by and large.
And would it have been helpful if that had been available to you earlier?
Yes, I think. Well, from my service, we didn't run out. We didn't run out of gloves and aprons, and because we ran out of sanitising gel, I did buy soap dispensers and put them in all of the houses that we were attending, so that there was means. And I also provided the big blue paper rolls. For to help with hand washing and hand hygiene. So we did that. We just did that automatically as soon as we realised. So that was our contingency, if you like, until the hand sanitising gel became available again.
And was that were those items that you had to pay and source?
Oh, I did that, yes, prior to the portal. Once the portal opened, we got more supplies of everything, and we were given hand soap and we were given hand sanitising gel. Yes.
And you've said in your statement that your usual PPE supplier told you that the government was prioritising the NHS and care homes.
Absolutely. When at the beginning of the pandemic, we thought, right, well, we had a stock, but we thought, well, we could do with some more. We couldn't get any. We tried to order it on Amazon, from China, and we put our order in, but nothing ever arrived.
And how did that make you and your employees feel being told that?
Well, I was just relieved that we already had a stock, to be honest. At that time, we were just thinking about right now. We weren't thinking about 3 months ahead. So I was happy that I had that stock. And then the portal, eventually did open, and we were able to top that up. And then we had a consistent supply, which was, I think that was, it was measured by the government according to how many clients that we had. It was proportionate to that. So obviously a bigger company with a lot more clients would have had a lot more PPE. So I think that was correct.
And I think you've said that around the same time as you were able to access the PPE, you were also able to access COVID-19 tests for your staff.
Eventually they came through, yes. That was a bit later.
Okay. What had your experience been in trying to access tests up to that point?
Very difficult. They were at the beginning, when the test became available, they were distributed through local pharmacies. And in theory, you could go in and get them for your service. But the pharmacies just protected them. Rightly so. I think there would be people going in trying to get them. But that just made it really difficult for us to get them. So again, once the supply came through the portal, that just relieved that burden. It was a burden going around all the pharmacies trying to get 5 packets here and 5 tests there. And we needed them. We needed them to test before each shift, so it was complicated.
Yeah. you've said that you think that was a bit later. Can you recall when it was that you?
I
No,
can't.
that's it.
I wouldn't like to say. Sorry.
Not at all. And did your staff follow the guidance on regular testing once it was introduced, or did you have any implementation issues?
Again, I think the staff were sceptical. They wanted tests to know whether they had contracted the virus. So if they weren't feeling well and they would test. But then when it became a rule that we had to test before each shift, well, your shift starts at 7 o'clock in the morning, you're up early, you're going to be, you didn't get to bed till 11 o'clock the night before from your previous shift. A lot of them just, they didn't want to do that. It was hard to persuade them to do that. And I think at the beginning, in the fear, at the beginning, they were grateful. But then as we became more confident and we'd all been vaccinated, and then it was more difficult to persuade them to do that regularly. And I think there was an administrative burden for me to collect all the results, and I was working, and that was just another layer of admin, if you like, that I had to monitor that and gather the results and report them back. And it was just complicated. It was just another complication.
Mm. And just focusing for a moment on the clients that you and your workers were seeing, did the use of PPE cause any difficulties for communicating with clients or any challenges there?
We did have challenges with that. First of all, our clients knew their staff. They knew who to expect. They would look forward to the visits. So suddenly the staff are coming in with a facial covering. Well, and especially if they were deaf, then you've got someone hard of hearing, can't see your lips. That was complicated. You couldn't see facial expressions if you were, you're trying to, when you're looking after someone who's elderly, vulnerable, you want them to know that you're happy, that you're confident, and that shows in your body language and your facial expressions, and that was all gone. So someone with dementia who doesn't understand what's happening out in the wider world didn't understand why they couldn't see the face. Sometimes we'll put a smile on the masks.
And again, sorry, I don't want to...
That was all just,
Yeah.
we just tried to, we used, the mask was for safety, obviously, but we still had to try and keep that engagement with the client.
And again, was there any support or resources available to perhaps help with some of those communication difficulties that your staff were facing?
Not that I remember.
Again, would that have been helpful?
Yes, I think so, yes.
You have addressed your experience during the pandemic with the CQC and the local authority in your statement. Did you receive any support from the CQC, and was it helpful?
I did. I received a telephone call from my inspector. It was a brief chat, and he did ask how I was and how was I coping and how was the team coping. So I did receive that. It's a drop in the ocean, given the amount of fear and disruption to the service and concern for everything. We did receive written acknowledgement of our service as well. We received a letter from the Department of Health and Social Care. I believe it came from Matt Hancock, and that was all about how the department was aware of our difficulty and trying to support us and giving us that support. We also received a letter from the chief nurse, and we received a letter from the leader of the council. And that was nice to have that acknowledgement, and I was able to circulate those letters on the group chat, photograph them, put them out, so everyone knew that acknowledgement was there, and that was valuable and helpful, I think.
How do you think you could have been better supported?
I think in terms of the guidance that we were getting, I felt as though the guidance was aimed at health and it was aimed at care homes. There was obviously huge concern over care homes and how they were caring for people with or either had COVID or protecting them from COVID. And there was huge concern about that. And I think the information for us was either tacked on the end of that or there was just nothing. So we had to pick out anything in the document that might relate to our service rather than reading, actually, domiciliary care can continue as before. Continue what you're doing. That would have been enough. rather than us just having to read everything through reams of information coming in our direction
And
to
I
be
think-
interpreted.
And I think you've said that you felt supported by your local authority, which
Absolutely,
you've
yes.
referred to today. What were some of the examples of the positive support that you felt from them?
Well, we continued with, we have regular meetings, they're called provider forums, and there's training as well, and that all went onto Teams so that we could still communicate with each other and still see each other, which was really useful. And, over time, we would say, wow, it would be lovely when this is over and we can all get together in person again, and look forward to that. But we did have that contact with them, and they made that effort, which was really helpful.
And finally, Ms. Parkinson, I would like to ask you, if I may, if you or your employees have felt any long-term impact of the pandemic?
It's a distant memory now, but the memory is overriding is of fear and complication and difficulty. We have lasting problems still with GPs, still getting access to appointments and doctors' visits. We've still got problems with that because we can't during COVID, the complication was just getting access to getting through on the phone. But now there's different phone lines that are set up for health professionals. We've been told categorically we can't use that number. We're not part of the healthcare team, and that really doesn't align with us working collaboratively. Health, GP, nurses and social care should work collaboratively because the person that's important is the patient. It's the person that we are supporting. It's not about us wanting to be important. It's about getting the right service that's needed for our client. And to be told that we're not part of the care team, it doesn't sit well with us.
Thank you. My lady, that concludes Ms. Parkinson's evidence.
Ms. Parkinson, I've heard a number of accounts of the problems when people go from home to home and how that can increase transmission. Did you have that? Presumably your staff would visit more than one client in a day.
Absolutely, yes.
Did it ever become a problem for you?
No. We were classed as care workers, so we were on the road. Everyone else was locked down, but we were able to we had to go to work, but that was part of, the only way that we could do it is to go and visit someone in their own home. And you would repeat that throughout the day, so there'd be morning, lunch, tea, bed, and you would see them. So you'd be travelling from various home to home, and there was no restriction on that because there was no other way of doing it. Right at the very beginning, we tried to minimise contact and we did reduce some of those calls or merge them together. But that was just a very short period until we were vaccinated, we were confident, and then we went back to normal service. But there was no restriction on that. And it didn't cause us a problem because we're supposed to be social distancing, and you can't do that in a car. The rule was one person in the front, one person in the back, and all the windows open. We did that. We did the best that we could to prevent transmission, and that was our prime focus, to prevent transmission.
I was just thinking, when you were being asked by Ms. Hands about the PPE, presumably when you talk about masks, you didn't have any at the beginning and then you had to get some. Presumably you only ever got the fluid-resistant surgical mask with the blue.
That's right, yes.
Given what we now know about the nature of the virus, so wearing those masks and your staff going between different clients' homes, you still didn't end up with a problem of transmission. So you obviously must have taken.
That's right.
Very great.
We didn't. We didn't have any transmission. We didn't have any. The only of the people that we were supporting, the only ones who caught the COVID when they went to hospital for an X-ray or an appointment. They come back with COVID. Yes, but not within our service at all.
And the message I've been getting from people like you, those who run care homes and now domiciliary care, is basically, it's all about recognition of your sector.
Absolutely.
Isn't it?
That's all. That's all.
And getting you, the point you made just now about the GPs, that's part of it, is lack of the recognition
Absolutely.
of the service you're providing.
Mm-hmm.
Yeah.
It is. And that's all we want.
Thank you very much. I certainly have got that message. So thank you very much for all that you did during the pandemic to look after your clients. I'm sure they were extremely grateful. The 101-year-old, did they have any family around?
They did. And yes, unfortunately, they couldn't visit. No. And from a daily visit from her son, from a daily visit to no visits at all, he was just entirely grateful that we were continuing to visit. And yes.
Well, thank you very much for your help with the inquiry and all that you did during the pandemic, and obviously to your staff too.
Thank you very much.
Thank you.
Yes, good morning, my lady. And may we please call Mr. Kevin Mitchell?
Yes. I swear by Almighty God.
I swear by Almighty God
That the evidence I shall give.
that the evidence I shall give
Shall be the truth.
shall be the truth,
The whole truth.
the whole truth,
And nothing but the truth.
and nothing but the truth.
Thank you, please.
Thank you. Good morning, Mr. Mitchell. I'm going to ask you some questions arising largely out of your witness statement, which is dated the 11th of March 2025. Just in terms of your background, you've had a long career of public service and you've been involved with the Care Inspectorate since its formation in April 2011. And in August 2015, you were made the Acting Director of Inspection and then became permanent in 2016. Is that correct?
Yes, that's correct.
So during the time of the pandemic, then, you were still in that role?
I was indeed.
Thank you. I'm just going to ask you some general questions then about Care Inspectorate and its role within the adult social care sector in Scotland. You set out at paragraph 10 of your statement that the Care Inspectorate is the independent scrutiny and improvement support body for adult social care services in Scotland. Is that correct?
Yes, that's correct.
And you emphasise there the Care Inspectorate's independence. Is that independence not only from Scottish Government, but also from the various other bodies in Scotland, such as Healthcare Improvement, Health and Social Care Partnership, and Directors of Public Health?
Yes, that's also correct, yes.
Thank you. I'd be grateful if we could please have INQ 475130, page 5 on the screen, please. And just paragraph 21 there. You set out, in broad terms, the Care Inspectorate is responsible for registering care services, inspecting care services, and then just slightly over the page, taking enforcement action when the quality of care in care services is not good enough. I'm accepting it's a very broad overview. Is that the constituent parts of what we talk about as regulation?
It is a broad overview, but that would accurately describe our broad responsibilities.
And from your perspective and from the perspective of Care Inspectorate Scotland, why is regulation of adult social care services important?
It's important because we ensure through the work that we do that the standards of care are sufficiently high. When they do not meet that standard, we take action. Enforcement action is a last resort, but we'll use the scrutiny. Our general approaches to inspection are done in a way that also is geared to support improvement, and in certain circumstances the organisation will provide targeted improvement support to individual services and providers. And as I say, the enforcement action is a last resort, but if the standards of care are so poor, we won't hesitate to use those enforcement powers.
Thank you very much. I'm just going to ask you to slow down ever so slightly. We've got a stenographer who's trying to keep up, okay? The care inspectorate's role then is set out largely in the 2010 Act, and it brings support services and care home services within the regulatory remit of Care Inspectorate Scotland. Is that correct?
Yes, that's correct.
Unlike in Northern Ireland and Wales, it's simply a care home service which is registered. There's no distinction made between residential homes and those which have nursing provision. Is that right?
The registration category is care homes, and you're correct that some provide nursing care but others don't, but the category of registration is care home.
During the pandemic, did the lack of that information as to whether a home was simply I don't use simply in a pejorative sense, but a care home or a residential home or had nursing provision, did that have any impact on Care Inspectorate's ability to have oversight of the sector?
No, we have a quality framework that we inspect against, and it's the same framework for both, for that service type, which includes those that provide nursing care and those that do not.
And if I can ask you about a specific point then, in terms of, would Care Inspectorate have the information as to which homes on its register would be able to isolate residents? Is that something which was collected either before or during the pandemic?
Not, we have an annual return that tells us and distinguishes those care homes that provide nursing care and those that do not, but we don't have information that would tell us about how residents might be isolated in the event of an outbreak of infection.
Thank you. I would just like to now move on and spend a bit of time this morning talking about regulatory inspections. You set out in your statement in quite a fair amount of detail about the methodology, regulations, standards and quality frameworks. I'm very grateful for that, but I would like to perhaps focus at this time on timeframes for inspections. So if I could have INQ 475130, page 34 and paragraph 107, please. And you set out here that regulations from 2012 provide that some types of care services, care homes and support services must be inspected at least once per year, and the inspection of services of these types must be unannounced. Prior to the pandemic, was the Care Inspectorate able to inspect all of these services once a year?
Largely, yes. I think it's important to just point out that the year is defined as the 1st of February to the 31st of January in legislation. So in effect, an inspection the gap between an inspection could be as long as 23 months and still comply with the legislation. But broadly speaking, yes, we did.
And if I just may put a perspective from the CQC, who we heard evidence from yesterday, in their supplementary statement, they set out that CQC recognises that on-site inspections are an integral part of regulation. I would just like to ask, first of all, do you agree with that? And second, just expand on why they are seen as such an integral part of regulation.
Yes. Certainly in our experience and my experience, the most effective inspection is that which is undertaken on-site, where you can see what is being done, where you can observe practice and where you can speak to, particularly to residents and any relatives who may be in the service. There are benefits, as we found during the pandemic, from technology, particularly when you want to speak to relatives who may not be present in the service when we inspect, but by and large the inspection in our experience is best done on site.
If I may, and forgive me if I'm jumping out of sync here, but follow up on that then. So there was some use of virtual technology by Care Inspectorate during the pandemic. Did that amount to inspections of residential nursing homes?
We did use it to test it out on some inspections. We very quickly realised it was important to direct individuals to show us things if we were using technology, because we were conscious that they may not want to show you what they don't want to show you. But again, the biggest advantage, I think, was we would conclude that it was in terms of making contact with relatives who you might otherwise not have the chance to speak to during an inspection.
And just, again, in terms of going forward in a future pandemic, would the Care Inspectorate be looking to use more virtual means, or as you say, is it not an appropriate substitute for in-person on the ground?
I think we would confine, in day-to-day activities, we'd confine the use of technology to engaging with parents, carers, in terms of our children's services, with professionals perhaps who might not be able to see on site, but by and large the inspection of the service itself should, as far as possible, be carried out on site.
Thank you. I'd now just like to move to some of the actions which Care Inspectorate Scotland took during the pandemic, and perhaps if we start at a decision which was taken on the 9th of March, which you outline in your witness statement at paragraph 213. Thank you. At that stage, it was proposed that there be a postponement of inspections of low/medium risk care services and only carry out on-site inspections of core assurances. Moving slightly further on, where there were specific concerns or the risk was assessed as high and the processes to be followed. So at that stage, there was a proposal to move to a more risk-based approach where lower risk homes would be left, but inspections would continue of higher risk homes. Is that correct?
Yes, that's correct. When the Chief Inspectors and myself met on the 9th of March in view of what we saw unfolding, we didn't envisage at that point not undertaking inspections, but we were proposing the scaling down of inspections and, as you rightly say, prioritising those that were of the highest risk.
And you said you didn't envisage a stopping of inspections. Can you confirm if it was discussed in this Gold Command structure, if that's the right term, on the 9th of March?
As you would expect us to do, I think we did cover all eventualities, and I think we did make mention of that possibility, but the two real options were the scaling down of our regulated care service inspections and indeed our strategic inspections. And that was for a determined a period of time that we envisaged as well. I think it was up until the 30th of June. But things, as I say, moved very fast in the coming days.
Well, perhaps we'll come on to that then. So I think the 9th of March must have been the Monday. And then by the 13th of March, a decision was taken, in fact, to scale back inspections. And if we could have INQ 000501-204, this was communicated to providers on the 17th of March.
That's correct.
And if we look, I think it's the third paragraph, please. Over the past week, we've taken the decision to scale down our inspections during this time. Just on the use of the terminology there, scale down inspections, it appears that no on-site inspections took place until the 4th of May. Was it a scaling down or was it a suspension or a stopping?
When we drew the document up on the 9th of March, we basically developed it on the basis of what we thought was unfolding. But as I say, it moved very quickly, and the document was approved on the 13th by our Gold Group. It was forwarded to government the day before for approval on the 12th. And in that ensuing period, we were beginning to get advice about the risk that inspectors might pose in terms of transmitting and spreading the virus if we did go into care homes, and there was a decision taken to cease those inspections.
So except it was a ceasing as opposed to a scaling down?
Yes.
And just then going back, the factors which played into that, what was the underlying reasoning for the Care Inspectorate coming to this decision?
It was primarily on the advice of Public Health, who were very concerned about the risk inspectors would pose in terms of transmitting and spreading the virus, particularly into care homes that did not have an outbreak.
And was that advice produced in writing, or was it this outcome of discussions which took place between yourselves and public?
I think most of that would have been through discussions. I was never able to find a document as such. I would imagine that those discussions would go directly to our Chief Executive of the day, Peter MacLeod, but certainly there was a decision made based on that advice.
Thank you. Just returning then to this paragraph, which should still be on your screen. Final couple of sentences then, please. We are only making visits to services when absolutely necessary. What was the threshold which Care Inspectorate Scotland had in their mind at that stage?
I think we would take enforcement action of the most serious kind when there was what we deemed serious risk to life. So I think what we were saying here was trying to acknowledge and achieve the correct balance between inspecting only when it was absolutely necessary and actually just carrying out business as usual, as we would call it. So again, this was us, if you like, making the plans from the week of the 9th onwards, getting the decisions that to the document that we produced on the 9th ratified, but advice starting to be given, and even in terms of this letter going out on the following Tuesday, I think it was, the 17th, the advice was still coming through, and really we did not go out on inspection again after that particular point.
On reflection, is it considered that threshold, you've mentioned a serious risk to life, was that too high on reflection to guarantee that oversight of the adult social care sector could continue?
I think it was a difficult to put an absolute measure in there. I think what we were trying to differentiate and be proportionate in our response was to acknowledge the risk by not inspecting routinely low and medium risk services. But if a service was high risk, and there's a number of, we have a risk assessment tool that would define that for our staff, we felt that we needed to reserve the right to go out and inspect if it was absolutely necessary to do so. But of course, we then received public health advice more formally, which really made that very difficult, in fact, to do without their agreement.
Okay, and perhaps I'll come on to some of the public health advice that you were receiving in due course this morning. But I would wish to explore, you mentioned that you felt that this decision was proportionate. I just wish to explore perhaps a couple of perspectives on that. In particular, could I have INQ 520272? And this is a witness statement from a Miss Kilby, who has given evidence or a statement on behalf of COVID bereaved, or the Scottish COVID bereaved, forgive me. And states paragraph 102, and again the last couple of sentences. Scottish COVID bereaved members consider that an inspector wearing full PPE would not have been a significant risk and could have identified areas of concerns in homes in a timely manner. What, if any, consideration was given to inspections continuing, but having inspectors subject to or having appropriate PPE or testing available to them? Was that an option which was considered?
At that particular time, one of the difficulties that we encountered was that the services themselves were struggling to get sufficient supplies of PPE, and we ourselves had no supplies of PPE, and in fact we only obtained our first supplies just towards the last week in April of that year. So again, that perhaps is one of the lessons we would have for the future, that we should perhaps, whilst recognising the importance of prioritising frontline services for PPE, both health and social care services, we perhaps should have been a bit stronger in making an argument for being supplied with PPE ourselves much quicker than we were.
And if I may follow up then, just in the second limit of that was PPE and testing. When did testing become available to care inspectors?
We were not prioritised for either PPE or testing. The priority initially directed by Scottish Government was understandably the frontline services, health and social care. There was limited testing in the initial stages of the pandemic. What I did manage to do, learning from that, was I managed to get us prioritised for vaccinations as the same priority as frontline professionals in the December of that year. But again, perhaps with the benefit of hindsight and learning, we should have made a stronger case to be prioritised for PPE and testing, as I subsequently did for the vaccinations.
On the making of any type of case then, in March 2020, did you or the Care Inspectorate raise the issue with Public Health Scotland or the Scottish Government saying we should be prioritised in March 2020?
I'm not aware of us making as strong a case as we should have done. I think our role at that time was trying to help the services themselves, some of whom didn't have sufficient supplies of PPE, were not changing enough, and some who were struggling completely to get supplies. So we were the conduit and had a team that we established, a team that we called the Flexible Response Team, and we, through our daily and some weekly and sometimes daily contact with care services, we were establishing what supplies they had, if they had sufficient. If they didn't or didn't have enough, we used those members of staff and the pathways that had been made known to us to try and get those services prioritised. So I suppose our focus, like everybody else, was on the frontline services, and we perhaps didn't think enough about ourselves.
And then just so I'm clear, when did regular testing become available to care inspectors?
To be honest, I couldn't recall the actual date, but it was many months, a good number of months down the line from frontline staff, because I say there was limited testing available.
And even departing them from the issues of PPE and testing, would the risk posed by a single inspector or a small inspection team attending at a home in the absence of visiting, would that not have been appropriate to guarantee oversight?
I think if we, with the benefit of hindsight, if we had, and what we know now, which we didn't know then in terms of our understanding of the virus, I think if we had adequate supplies of PPE, which we didn't, but if we did have adequate supplies of PPE, that would have been sufficient, and clearly we would have to comply, because again, whatever we might feel we would want to do, we were restricted by the views of Public Health Scotland, who were very concerned about any proposal for us to inspect. And indeed, the first occasion I proposed an on-site inspection in April, the 3rd, 4th of April, that request was refused, or it wasn't agreed, to put it that way.
Mr. Mitchell, I totally understand the importance of maintaining inspections if one can, and how if your inspectors had had proper PPE, they could have continued. I think one of the problems I've got with prioritisation is that it's so difficult for the person who has to decide who gets priority. I think you've partly acknowledged that in your evidence.
Yes, I think that's absolutely the case, my lady. I think I had some sympathy because the supplies were limited, not just in Scotland, but throughout the UK. And clearly, it's very understandable that you would prioritise those to frontline staff, those nurses and doctors in hospitals, and the care staff in care homes and providing care at home, domiciliary care. I think it's perfectly understandable, and it would go somewhat against the grain for us to push so hard to try and get that for ourselves. But I think with the benefit of hindsight, and perhaps an environment where we'd have easier access to PPE in the future, I think there would be a responsibility on us to ensure that we thought about ourselves as well as the frontline workers.
But does that not go back really to the point that because we were so ill prepared, we didn't have a test and trace system that you could scale up, we didn't have facilities to manufacture PPE in the UK sufficiently quickly? I mean, it all goes back to being properly prepared, doesn't it?
I think that would be the root cause, Emily. I would agree with that.
Thank you.
Sorry to interrupt.
No. Thank you, my lady. Perhaps if I move on then, and we just have a brief discussion about perhaps some of the mechanisms which Care Inspectorate put in place while inspections were not taking place. And if I could refer to INQ 320177 and specifically page 3. This is a report prepared by the Care Inspectorate entitled CI's Role and Purpose and Learning During the COVID-19 Pandemic, and was published in August 2020. If we focus on the left-hand side column here, and starting in the 3rd paragraph, it is set out that inspection is just one element of the Care Inspectorate's role. And far from sitting back, we intensified our oversight of services and rapidly put in place a raft of robust measures. I'd just like to discuss some of those measures with you. In the 4th paragraph then, you outlined that there was, or Care Inspector outlines there have been increased levels of contacting every home weekly and sometimes daily between the 1st of April and the 26th of July 2020. These contacts, were they made by inspectors themselves?
They were, yes.
And in terms of these contacts or phone calls, I assume we're talking about, is that fair?
Yes.
Yeah.
Yes.
Were they simply to monitor and provide support, or were they performing some type of regulatory oversight function?
I suppose it was both. They would contact the care services at least weekly and sometimes daily if particular risks were identified. There would be various things that they would do. They would check that they had sufficient supplies of PPE, as I've already said. They would consult with others to get them supplies of PPE if they didn't. They would check the services and the manager and the staff's understanding of the latest guidance, whether they had access to the latest guidance on infection prevention and control, on social distancing, and they would check to ensure that they had that and were following it and gaining assurance that they were following it. They would discuss with the service any notifications that we had received from them. We have an electronic system where the services send us notification about a range of things, from a change of manager, notification of a death, notification of an accident, a fall, a medication error. So if we had received, in this case, particular notifications about infection outbreaks or indeed deaths, we would discuss those with the service in those contacts and make sure they had the staff, that either had sufficient staff, and if there was any deficiencies in any of that, we would seek to provide them with the guidance. We would help them understand it and signpost them, or indeed if they were needing support from the local health and social care partnership, we would make sure that that happened.
Before we move briefly then on to the enhanced notifications that you're talking about, these calls and these contacts, could they in any way replace the oversight or assurance provided by on-site inspections, or were they even intended to?
They would never do all that an inspection would do, but they certainly, I think, were as much as we could do in the circumstances, and they certainly proved beneficial, and we received quite a lot of positive feedback, including from a member organisation, Scottish Care, and Dr McCaskill, who acknowledged the support that those calls actually provided. But they would never replace an inspection.
And if I may move on then to the 5th paragraph on the screen here, where the Chief Executive is talking about an early warning system of enhanced notifications put in place, requiring services to tell us about both suspected and confirmed cases of COVID and staffing levels affected by COVID. This is the red, amber, green system which you discuss at length in your statement. Is that correct?
Yes, that's correct.
And were a service to send in one of these enhanced notifications and it would be flagged red in terms of staffing issues, what action would Care Inspectorate Scotland have taken from both a regulatory and a support perspective?
Yes, we monitored these notifications over the 7-day week, including Saturdays and Sundays, and we made contact, as I've described, with those services, particularly those services that had assessed themselves at either amber or red, to discuss the specific situation of that service with the manager and staff. And depending on what we found and what we were told and how we assessed the notification, we were working by this time very closely with the Scottish Social Services Council, who are the professional body that registers individuals who work in social work and social care in Scotland. And we were also working closely with health and social care partnerships, who were geared up to provide clinical and care support. So although we didn't have the staff to provide those services with, we actually ensured that they got additional support, additional staff, if that was needed, by our liaison arrangements with health and social care partnerships and indeed the Scottish Social Services Council, who had that particular role to identify staff that were needed.
I may just ask you very briefly then on the Scottish Social Care Council and their role. The inquiry has heard some evidence that perhaps there isn't a register of care workers across all of the devolved administrations. In this context, is this where the benefit of a register really comes to the fore?
It wasn't a role that they had routinely, but it was a role that proved extremely worthwhile during the pandemic, because they were able to tap in, whilst they have a register of people who are currently registered to work in social work and social care, they were able to access people who had recently gone off the register and see if they would be prepared to come back. And again, I think that was work that they did in conjunction with health and social care partnerships, Scottish Government, and indeed NHS, NSS, which is a special health board who provides support to the NHS in Scotland.
Thank you. Now, these enhanced notifications, they're obviously depending on what the services are reporting back up the line to the care inspectorate. Is that correct?
That's correct, yes.
There was very little or no objective or independent oversight of.
We did provide them with a very simple definition that they could use in terms of how they might categorise themselves as red, amber or green. Clearly there were occasions where, when we explored it with the service, that we didn't quite agree with their categorisation that they'd given themselves, but by and large they did actually use it and use it well.
If I may then just return, having outlined these mechanisms which were put in place, to the witness statement of Miss Kilby, which appears again at INQ 520272, in particular paragraph 100. She sets out that there were no routine physical inspections of care homes by the care inspectorate. This, along with the lack of GP visits and the inability of families to visit due to lockdown restrictions, meant that the usual checks and balances were missing. Did the lack of routine inspections contribute to, in effect, a deficit of oversight of what was happening across the adult social care sector?
There certainly wasn't the same oversight in terms of on-site inspections by the care inspectorate, and we were also aware, and I think government in the fullness of time acknowledged, that there wasn't the same support from community health services, which included GPs and allied health professionals and public health nurses, mindful that not all care homes have nursing staff of their own. That clinical support that a care service might have been used to before the pandemic wasn't there in all circumstances during the pandemic.
Thank you. I'd just like to move on to inspections then restarting on the 4th of May 2020. And before I do so, I do acknowledge that you were very intimately involved with this decision, and that obviously it related to concerns arising in a specific home at a specific time. I personally don't think we need to open up the nature of those concerns at this time. But on the 4th of May, an on-site inspection takes place. And there had been some engagement with the service in question and the care inspector and other bodies, and assurance was provided, which maybe turned out not to be 100% accurate. Does what happened on the 4th of May and the build-up to it demonstrate that the assurance mechanisms in place weren't 100% adequate to protect users of services?
I think what you're referring to there was part of the response put in place on the 17th of May by the then Cabinet Secretary, and that was termed an oversight assurance arrangement, principally led by directors of public health. And what I think you're alluding to there is the telephone assessments.
Well, forgive me if I've not been abundantly clear at all. We'll come on, of course, to health and social care partnerships momentarily. Point being that in the build-up to the 4th of May, you become aware of concerns in a specific home. Is it not demonstrate that perhaps lack of oversight, that those concerns were able to fly under the radar, perhaps, for a period of time at least?
By that particular time, we were required to get agreement from the directors of public health before we went on site. I'd previously, about 4 weeks earlier, tried to do that in respect of one care home in the west of Scotland, which was at in a critical position. And when I'd contacted the Director of Public Health then and proposed an on-site inspection, that Director of Public Health came back and told the Chief Executive the following day that there had been a decision not to go on site, and that it would be dealt with by way of a call from the consultant, Director and Public Health consultant, and that the inspection wasn't necessary. So I suppose what I'm trying to say is that we were required to get Director of Public Health agreement before going on site, and whilst I didn't get that agreement on the 4th of April, I did get it on the 3rd of May, although it was very difficult and took some 3 hours back and forth between the Director of Public Health to get that agreement.
Again, I don't think we need to go into the specifics, but from your experience of what went on perhaps in April, you say that Directors of Public Health stopped an on-site inspection. What do you understand was their motivation for that? And again, I don't need the specifics, just perhaps the general underlying principles.
I think this was a care home that had 30 of their staff had been off. It was a large care home. There had been 8 deaths. It came to our attention because actually one of the inspectors who was making these phone calls.
Again, perhaps I'm very just cautious that we don't want to get too caught up in specifics.
Sure.
Generally, you indicated you were minded to go and inspect homes if there was concerns.
Yes.
Was it a fear of footfall into care homes you consider that was motivating the directors of public health to maybe just press pause on that?
I don't know what. I think they were very nervous about us going into the care home and preferred to deal with it by way of conversations between clinicians and staff in the care home.
Okay, thank you very much. Inspections restart then on the 4th, and we get to a situation where by the 11th of May, Care Inspectorate is trying to introduce a somewhat more routine arrangement based on primarily intelligence and risk.
Yes.
And if you could have on screen, please, again, referring back to your witness statement, INQ 475130, and particular table 6. And forgive me that time today perhaps doesn't allow us to explore the intricacies of every policy development. But we have here the number of care home inspections completed between the 1st of April and the 31st of March each year. So we can see in 2019-20 there were 1,129 inspections. That drops to 603 during 2020-2021. That's perhaps maybe not surprising given what we've discussed this morning. And there's an increase back up towards over 1,000 by the time we get to 2022-23. There appears then to have been a return to almost pre-pandemic levels of inspection. Was that a deliberate policy decision of Scotland to try and return to the position as it was before?
One of the things that we did, clearly we didn't do as many inspections in that period where we ceased inspections for the short time in 2020. But the other significant difference was we, with the support of the Cabinet Secretary, when we inspected and found that significant improvements were needed, we followed up by doing further inspections of that same service, not just to check that improvements were made, but to ensure that improvements were not only made but sustained over time. So what we did was we found ourselves inspecting the same service 2, 3, 4 times in relatively quick succession to get that assurance that, as I say, that not only improvements had been made but were sustained over time. Now that meant if we were going back several times to inspect a particular service, we couldn't do as many other services. So that somewhat explains the lower figure. But the intent was to do as much as possible with the resource we had, mindful, of course, that many of our own staff were shielding and had underlying health conditions themselves that prevented them from going out on inspection.
And this is what you described then as the move to intelligence and risk focus, perhaps more than time frames, maybe.
Yep.
Before we leave the subject of inspections, I would just like to give you an opportunity to cover some general reflections, perhaps. So, returning back to a perspective of the CQC, in their addendum statement, they set out, in the event of a future pandemic, strenuous efforts should be made to protect the ability to carry out on-site inspections as much as is practically possible. They acknowledge that on-site inspections play a vital role in ensuring the safety and quality of services, but it should be recognised that on-site inspections cannot safely take place in a pandemic if they increase risk to those in care settings. Do you agree that in the event of a future pandemic, strenuous efforts should be made to try and protect the continuation of on-site inspections?
I would think on the basis of what we know now compared to what we know then, that there would be more consideration given to maintaining those inspections. But it's difficult to second guess what the constraints then in the future might be. The constraints around us for this pandemic was the lack of PPE. That was a significant factor, and indeed the constraint imposed on us in order to obtain Director of Public Health agreement. So again, thinking ahead, it's difficult to second guess what constraints might be evident might be placed upon us in the future, but by and large I would agree that as far as possible inspections should continue, but there needs to be a balance between the benefits of that inspection against the risks they might pose.
And forgive me, I'm not trying to be unfair, and I appreciate it's impossible to speculate on what a future pandemic may look like, but is there anything practically the Care Inspectorate could do to ensure that that continues in the future?
I think one of the things that I've certainly reflected on is there would be some merit, I think, in mirroring approaches by emergency services to major incident planning, because I think if something similar was done involving the public bodies in Scotland who are part of the pandemic response, there might be a greater understanding of each other's roles and responsibilities, constraints that might have been helpful if that had taken place before the pandemic that we had.
I think we've already covered successfully the issue about the role of virtual inspections in the future. But do you consider that there's need for clear and adaptable protocols setting out what would happen, the use of different types of inspections, both fully remote, in person, and a blend of the two? Would it be useful to have clear, adaptable protocols which are reviewed on a regular basis, and perhaps even tying that to this more practical crisis management exercise that you've just described?
I think it's important, and we do have contingency planning arrangements of our own, which we do exercise, but that's done on a single agency basis, if you like. But I think for me, the importance will always be on, wherever possible, carrying out on-site inspections. Yes, we will use, no doubt, technology to support us in that, but the primacy in my mind would be to continue carrying out on-site inspections as far as you possibly can, and obviously making sure that there is an understanding of our role and functions more widely across the other organisations.
Thank you. If I may move on then to just engage with you about Care Inspectorate's role during the pandemic, and in particular its role in relation to a number of other bodies and organisations which exist in Scotland. I really would like to focus perhaps not on the governance side of it, but on the impact on the Care Inspectorate, and in particular on the adult social care sector. And the issue of the role played by the Directors of Public Health is, you've referenced it a number of times already this morning. I would just perhaps like to explore that a bit more. There was a deep dive conducted by the Scottish Government Resilience Room on the 14th of April 2020. I don't think we need the minutes up, but the two outworkings of that relevant to Care Inspectorate were to visit every single care home with a focus on IPC and to reinstate some inspections. That was on the 14th of April. By the 1st of March or 1st of May, correspondence goes from the Chief Executive saying this has not happened because of concerns on the part of the Directors of Public Health. Is that correct?
That's correct, yes.
What I'd really like to just bottom down very briefly before we perhaps take a break then is, in terms of the knowledge, the experience of the sector, was that held by Care Inspectorate or was that held by the Directors of Public Health?
I'm not sure what the level of knowledge or understanding of the care sector would be in public health. The Public Health Scotland was a body that was created on the 1st of April 2020. So I think it's important terminology. I'm talking more about the Directors of Public Health as opposed to Public Health Scotland and the role they played. Sorry, my apologies. The Directors of Public Health, there's one director in each of the 31 health and social care partnerships in Scotland. So they would, I think, have an understanding of the care sector, because their responsibilities, as I understand them, are around the environmental hazards and infections that might arise in terms of providing preventative guidance and indeed in responding to infection outbreaks. So they would have an understanding of the care sector at that local level, and would indeed be responsible for providing advice even around, for example, norovirus prior to the pandemic. So they would have a knowledge of an understanding of the sector.
You've already flagged some of the issues which arose in terms of proposed inspections early in April and perhaps some issues which arose in May then. And your statement, you do flag that the involvement of the Directors of Public Health created some degree of ambiguity. I suppose my question is, was enough done on reflection on the part of the Care Inspectorate to emphasise to the Directors of Public Health that inspections of care homes were absolutely necessary?
Yes, there was repeated representation made to directors of public health that that we would need to inspect it perhaps in certain circumstances, but it was quite clear that there was a high degree of nervousness about us going on site, and that was pretty much confirmed at the deep dive exercise that you referred to, where it was in fact a bit confusing, because in one respect it said that all care homes should be visited, and then in the same document it said some care homes would be visited, but it made very clear that no visit could take place unless under the clinical direction of Directors of Public Health.
And if I may ask you this final question on this subject, did the need to get that approval from the Directors of Public Health, was that a positive overall, or did that add a further layer of complexity to the process, which perhaps at times may have inhibited Care Inspector from taking the action they felt necessary?
I think we were keen to leave an option open for us to go against public health. We felt we wanted to have that option if necessary, but to be honest, it would have been a difficult. We didn't, in fact, do that and go against public health advice. If we did, that would have been quite a serious situation potentially in terms of liability and responsibility for us. But it was one that we left the option open, but it was never used.
Thank you. Well, lady, I don't know if now might be a convenient time to take a break.
Yes, of course, Mr. Mitchell. You're warned, I suspect, Mr. Mitchell, that we take breaks, but I promise you we'll finish your evidence before lunch.
Yes, thanks, Milady.
I shall return at 22.
All rise.
Mr. Beach.
Thank you, milady. Mr. Mitchell, if we may return to just discussing the Care Inspectorate's engagement with a number of different bodies and structures across the adult social care sector in Scotland. There was a directive received from the Scottish Government on the 17th of May, which led to the Care Inspectorate becoming involved in what are known as care home clinical and care oversight groups. Now, I appreciate that that terminology perhaps evolved a bit over time, but this was working with health and social care partnerships, and part of that role was to involve assurance visits to services were to begin, and oversight groups were to hold daily discussions. On assurance visits, were they inspections in terms of Care Inspectorate's role, or were they something completely different?
I have no doubt that the guidance was intended to provide clinical and care support to all the care homes, but I think some of the wording in the letter from the Cabinet Secretary and the associated guidance was perhaps confusing, and I think did cause some people to think that it was a secondary form of inspection, and indeed that subsequently proved to be the case, and some areas responded, I think, as was intended, and others were more in an inspection role, which was effectively duplicating our responsibilities.
If I may perhaps explore this issue with reference to the evidence from a witness statement from Dr. McCaskill of Scottish Care, and if I could have, please, on screen, INQ 509530. And if we may start at paragraph 128. Dr. McCaskill has considerable comment to make on this issue, but if I could try and boil it down to its constituent elements, he said that this led to considerable confusion within the sector. And then on to, and I believe it's the next page, paragraph 130, he sets out that this led to a clinical approach to care homes from practitioners, often did not have the experience to take into account the nuances of the context, and specific examples there are given of, in effect, residents' personal effects being taken away in case they presented an infection risk. Do you accept and agree that this layer and structure, these assurance visits, led to considerable confusion within the sector?
I would describe it as an inconsistent response, because some health and social care partnerships did exactly what was intended, but others didn't. I think it was the use of words such as assurance, basically that caused some areas to think that they were expected to do an inspection. And indeed, we know that some areas actually awarded grades and made recommendations. But I think it would be wrong to say that all areas did that, but it did lead to some confusion. And indeed, that was acknowledged by Scottish Government, who put out further guidance towards the end of that year in December, which clarified their expectations.
That was the guidance on the 14th of December. What year was that? Was that 20?
That was 2020 to clarify it. But again, it was 2 years later before they eventually changed the name to reflect more the role that was expected.
So there was clarification put out in 2020, and then the final.
It was still causing some confusion, and there was a final change made in 2020, and I think that was correspondence that was in the name of the government's chief social work advisor.
Final correspondence in December 2022,
yes.
Just so we're clear. Going beyond perhaps confusion, at paragraph 132, Dr McCaskill outlines how, having surveyed Scottish Care's members or conducted research, was noted that considerable harm had resulted from such a confused oversight and scrutiny model being imposed upon the sector. He talks about there being a significant reduction in staff morale as a result of these arrangements. Do you accept, or can you acknowledge that this did lead to difficulties for the workforce?
I think there were difficulties for the workforce. On some occasions, we found that messages that we gave were contradicted by some of the oversight arrangements. There was, in some instances, what we would term inappropriate responses in terms of infection prevention and control, and that was perhaps as a result of applying clinical standards in a care home and forgetting that actually a care home should be a homely environment. And whilst, of course, care homes should adhere to certain levels of infection prevention and control, when it comes to residents having soft toys, soft furnishings, that they place a lot of emphasis on, particularly if they're living with dementia, for those to be taken away from them, rather than the focus being on cleaning regimes. I think that did cause some difficulty and did cause some distress to staff.
And then just again, as a general reflection, was this additional process, these assurance visits, on reflection, was that a positive, or was it another layer of ambiguity or confusion to the
I think where it worked well, it was positive, in as much as it provided and ensured that those care homes received clinical and care support from, for example, GPs, allied health professionals, public health nurses, and indeed from others within the Health and Social Care Partnership. But it's fair to say that where the guidance was misinterpreted, it did cause some difficulty for us, for the providers, and indeed for the staff in those services.
Was there a role for the Care Inspectorate where the guidance, as you say, was misinterpreted, to escalate those concerns to the Scottish Government to ensure that the guidance was being properly applied? Yes,
absolutely. In each and every case, particularly those areas where we found that the arrangements that the partnership had put in place had given contradictory messages to our own, we made sure that we sat down with those individuals and talked them through the reasons for what we did and how that differed from what they did, and the reasons behind what we did. And we usually managed to achieve an understanding, but I think it was primarily because the individuals were applying clinical standards in a care home, which is, it's important to adhere, as I say, to certain standards of infection prevention and control, but it's not the same as a clinical environment of a hospital, for example.
If you have clinical teams supporting, just putting to one side the confusion about the wording and confusing it with your role.
Yeah.
But if you have a clinical team visiting a care home to support and they don't understand the kind of points you made about the importance of soft toys for a dementia patient or something of that kind, how did you, you say you had success in the care homes that followed the guidance as it was meant to be, but why didn't the same issue arise there with a clinical team
Yes.
trying to impose clinical IPC measures inappropriately on a care home?
I suppose it depends, my lady, on the individuals who are doing that work. They may have had different experiences. You know, we have nurses who are employed in care homes. Some may have gone on to work in health and social care partnerships, and indeed vice versa. So I think, again, it was the guidance, but perhaps there was different levels of professional knowledge and understanding of individuals who were tasked with that particular role. That would be the only reason I could think of explaining that.
Thank you.
Thank you, milady. Can I then move on to inspections undertaken alongside Healthcare Improvement Scotland? And again, this all arises from the same direction from Scottish Government of the 17th of May 2020. It leads to Healthcare Improvement Scotland participating in around 30% of inspections before the arrangement finally came to an end on the 9th of April 2021. Prior to the pandemic, were Healthcare Improvement Scotland involved in inspection of adult social care services?
They have never been involved prior to that with our regulated care service inspections, although we do undertake strategic inspections on a joint basis with not only Healthcare Improvement Scotland, but with the Education Inspectorate and the Police Inspectorate.
This was a relatively new phenomenon then in this context.
Yes, for regulated care it was.
What were Healthcare Improvement Scotland to bring to these inspections which Care Inspectorate couldn't?
Initially, it was ourselves that asked for support from Healthcare Improvement Scotland, and that was as early as the March of 2020, when we asked them to help with the telephone contact arrangements with care homes, and we started to use the staff from Healthcare Improvement Scotland on inspections from about the beginning of May, in fact, just after the first inspection of the care home that led to the recommencement of inspections. And the guidance that came out, when it came out, we'd actually already started using them on inspections, but they had limited resource themselves, and that was the reason that they could only undertake about a third of inspections.
And just forgive me if I've missed it, very briefly, what perspective were they to bring to these inspections?
To be honest, many of them had no greater or lesser knowledge than our own staff, because many of our own staff have nursing backgrounds themselves. So they were very much working collaboratively and making a very valuable contribution to the general approach to inspection, as indeed and in the same way as our own staff were. It's just that they hadn't hitherto been used to inspecting regulated care services.
I appreciate then by the time we get to the 9th of April 2021, there's a need to clarify the position that inspections are the realm of the Care Inspectorate. But earlier then, on the 21st of December 2020, the Scottish Government made a request or sent correspondence that all inspections going forward should be carried out jointly with Healthcare Improvement Scotland and must focus on the physical care needs for the residents. Was it appropriate that Healthcare Improvement Scotland would be involved in all inspections going forward?
I think, again, that was probably something that resulted from a misunderstanding of our role and the fact that we had, I think at that time, around 60 nurses who were inspectors working for the Care Inspectorate. And the request for HIS to become involved in all inspections just wasn't achievable, because they didn't have any more staff to give us other than the staff they gave us, which resulted in approximately 1/3 of inspections they were able to accompany us on.
In answer to my previous question, then, you said that in reality these staff from Healthcare Improvement Scotland had as much or the similar set of skills and experience.
In many cases, yes. I think there was perhaps a misunderstanding that the staff we employ as inspectors, some of them have strong backgrounds as perhaps managers of care homes, but others have nursing backgrounds, and I think that perhaps wasn't understood.
Well, I suppose to ask you the familiar question then, these inspections with Healthcare Improvement, did they add anything, or were they just another layer of process which perhaps maybe interfered with the Care Inspectorate discharging its statutory functions?
No, it was certainly helpful, because it allowed us to get round more services than we might otherwise have been able to, because if we were, for example, inspecting with two inspectors, if we hadn't had one from Healthcare Improvement Scotland with one from our own organisation, we'd have had less to go around, and we would have covered less in terms of the number of services we inspected.
You've outlined on a number of occasions this morning that there's perhaps a misunderstanding on the part of Scottish Government as to what exactly Care Inspectorate did and who exactly was employed by Care Inspectorate. In terms of the impact of all we've discussed, what was the impact then of Scottish Government's perhaps misunderstanding, in your opinion?
I wouldn't say there was everybody in Scottish Government didn't understand. We have very close arrangements with some parts of Scottish Government who do understand fully our role. I think we were engaging during the pandemic with parts of Scottish Government that we weren't used to engaging with. For one, that would be the Chief Nursing Officer's Directorate. Now, again, there was, I think, a suggestion, for example, that they needed to provide us with staff because it was important that we inspected the health needs specifically of individual and care homes, perhaps not realising that we'd done that for a number of years before the pandemic. Inspecting health needs as well as the broader care needs of an individual was something we were well used to doing, and I think that perhaps wasn't fully understood by all.
And as I say, the inquiry is certainly forward-looking. We'd be keen to ensure systems work better again in the future. So how could any misunderstanding or ambiguity across all these bodies, Government, Directors of Public Health, Care Inspectorate, Healthcare Improvement Scotland, and Health and Social Care Partnerships be avoided in the future?
I suppose rather than tackling each of those individual areas, that was what probably led me to reflect on how it might be helpful to mirror what emergency services do by exercising so that you can develop those relationships, those understanding of respective roles and responsibilities, the interoperability of individual contingency plans without waiting for the actual incident, in this case the pandemic, to happen. So again, I think the understanding of each other's roles, responsibilities and limitations is critically important, and that's best done sooner than later.
Thank you. Perhaps if I may move on to a couple of discrete topics, and again, the best place to view these from might be the evidence of Dr. McCaskill. So if I could have on screen, please, INQ 000509530, page 35 and paragraph 136, please. You set out across your statement that during the pandemic, the Care Inspectorate took on a greater role with regards to IPC. That came from both the deep dive and from legislation which was passed in the form of the Second Coronavirus Act. Dr. McCaskill sets out that there was a considerable deterioration in the working relationship between providers and regulators, and one of those factors was this increased focus on IPC. And then moving on, and forgive me, it's on the next page again, at paragraph 137, he states that prior to the pandemic, Care Inspectorate moved to a regulatory model which involved collaboration and engagement. However, during the pandemic, providers felt it was increasingly focused on scrutinising the sector. Do you accept that this increased focus on IPC led to, in effect, a lack of support to the sector, which was replaced with more of a critical eye?
I do think what is said there is entirely accurate, because the inspections that we undertook were not entirely focused on IP. Indeed, by that time, in response to emergency legislation that was enacted on the 29th of May 2020, we were required to report to Parliament every 2 weeks the inspections we'd undertaken, and we were specifically required to focus on infection prevention and control, staffing and PPE. And we actually included from the outset what we would refer to as the wellbeing indicator, so that we could report on wider wellbeing, because we thought that was important to do that. So it wasn't entirely correct to say that they focused simply on PPE. And whilst I don't disagree that it was the right thing to do, it was a requirement of that emergency legislation. And I think what perhaps is alluded to here is that services felt our contact arrangements in the period that we weren't inspecting were quite helpful. But of course, our primary role is to provide independent assurance. And yes, for those services where we were highlighting significant failings, I've no doubt they perhaps weren't too pleased with us doing that. But that was what our role and function is. And so I think part of what Dr. McCaskill says in his evidence there is correct, but other parts are not.
If I may briefly then just deal with these parliamentary reports, and again we're going to keep within the prism of Dr. McCaskill's evidence, and forgive me, I'm jumping back now to page 136, or paragraph 136. And another one of the factors, he says, which led to this deteriorating relationship. You talk about the reports to Parliament, and he says at paragraph 136 1.2, in practice these reports were often submitted, I assume that means submitted to Parliament, the Scottish Parliament, before the findings were reported to providers. Is that a phenomenon you're aware of?
No, that's not correct. What happened was that these reports, the inspections and the reports, by virtue of the legislation that was enacted, were required to be reported within 2 weeks, and that was a much tighter timescale than our normal reporting processes. But what we did was we ensured, as far as we possibly could, that our inspectors produced a summary of their evidence, their findings of inspections within 24 hours of the inspection, and they shared that with the service, with the manager, immediately. What I think perhaps is alluded to here is that we have a process in our normal reporting which is called error response, where individual services can challenge the findings, and we weren't able to do that because the timescales for the fortnightly reporting wouldn't allow it. But we did provide the summary of the feedback within 24 hours.
If I could turn briefly then to an issue of data, which is that in late 2020, and you set this out in your statement at paragraph 92, you were provided with access to what was called the Safety Huddle tool. And you outline your statement that you raised strong concerns from the outset that there in effect was a duplication of data provision, and that would impact on care service providers. Yeah. What impact were you concerned about on the part of care service providers?
The fact that, again, well-intentioned as it was, there was no doubt that there was duplication on the part of the care services. For some things, they had to report report to us. They were also asked to report to the Health and Social Care Partnership. And in respect to the daily huddle tool, they were required to input the same information to that particular tool. I suppose what we tried to do was we tried to reduce as far as possible, but we couldn't stop, for example, the notifications that services had to make to us, because that's a requirement of legislation and regulations. And if we take action, regulatory enforcement action, we have to often cite the notifications that services make to us, or indeed the absence of notifications that they should make to us. So it wasn't something that we could dispense with, although we were very sympathetic to the duplication that was obviously happening.
And then perhaps before I just move to some general reflections on your part, in terms of domiciliary care, I think they're called support services under the legislation. You set out in your statement that a limited number of inspections of domiciliary care agencies took place. In particular, if we could have, please, INQ 475130 and paragraph 577, please. You set out here that between the 1st of April 2020 and the 31st of March 2021, we carried out 657 inspections of regulated care services. And if we break that down, 16 of those inspections were for care at home services, and 28 were for combined housing support and care at home. Why were the numbers of inspections of domiciliary care agencies or support services so limited?
There was no doubt that was a decision we took ourselves in terms of the resources we had. We had limited resources. Initially, in the April-May of 2020, we only had 17 of our inspectors available to inspect. That number increased as time went on, but the priority determined by ourselves and in consultation with government was on the care homes, because of the risks that were there in respect of those services. there were similar risks in care at home services, and we did an inquiry piece of work that we reported on in the September of that year. Although it didn't involve inspection visits, we did a report, an inquiry which focused on 300 providers. And
I can't see that reference to that in your report, but I suppose just on reflection, you've used the word priority there. Was appropriate priority given to domiciliary care and support services during the relevant period?
I think given the risk profile of the care homes and what was happening in care homes in relation to infections, outbreaks and indeed deaths, I think it was right to prioritise the care homes, and being mindful that we weren't just inspecting, but we were going back 2, 3, 4, sometimes 5 and more times to make sure improvements were not only made and sustained. So that was quite a significant commitment to a service type that we would normally only undertake one inspection on. And it had to be at the expense of something else.
And just so I'm perfectly clear, the expense you're talking about was of oversight, assurance and support for domiciliary care, is that correct?
Not just domiciliary care, but all the other service types as well. The priority was to inspect those highest risk services, which happened to be care homes.
May I explore very briefly then just a couple of the recommendations you set out at the end of your statement? If we could have 475, 130, page 177 and paragraph 656. There's a series of bullet points here, and at the third one, you say that one of the learnings was to pay closer attention to the design of the buildings in which people live to keep them in safe but in homely environments, and subsequently the guidance used when registering care homes was amended to reflect some of the learnings from the pandemic. Why was it important that there was some focus placed on the physical infrastructure, if I may call it that, as a result of the pandemic?
The design guidance is intended for those planning or building new care homes or substantially renovating existing properties. But what we learned from the pandemic about infection prevention control, about ventilation, fresh air, it is possible to design care homes better to take account of those. So, for example, in a large care home, small group living is better. So creating spaces, if you like, that can be used to cohort both staff and residents if there's an outbreak is helpful. But if the building is designed to accommodate that, it's even more helpful. So whilst the obvious was designing in and making sure, for example, communal areas could be much more easily managed in a pandemic, it was also important to think of the wider context of new builds and existing properties.
Thank you. And then if we could just return then to this care inspectorate's regulatory role over the page at page 178. That's the fourth bullet point from the... You set out the regulation needs to be responsive to the needs of the sector, and where improvement is needed, support is provided and followed up quickly to ensure improvement is achieved and sustained. I suppose, as a final question, specifically with regard to your role as a regulator, what, if any, recommendations or improvements could be made to ensure that in the event of a future pandemic, the care inspector can perform its role as best as possible?
I think the care at home, the domiciliary care, is a really important one, because I think there needs to certainly be investment in care at home to ensure that people, older people in particular, don't remain in hospital longer than is necessary, and that means that they need to have care at home or in a care home. So, and that, if they remain in hospital after the period where they're deemed clinically fit to be discharged but can't be discharged, that's preventing other people. So I think there's the investment that's needed, but in terms of the risks, I think we need to also think about balancing the risks that a pandemic poses to individuals better with individual needs, choices, rights, human rights and wishes, and try and do that in a better way. I think in terms of Scotland, the importance of visiting, even during a pandemic, has been addressed in recent legislation that's awaiting royal assent, but that was a really important factor as well, and hopefully that's now in place will deal with that particular issue that arose during the pandemic about the access to loved ones, particularly essential visits at end of life, or for those experiencing distress, perhaps living with dementia.
And just specifically with regard to regulation, beyond what you've described already about the crisis management and the importance of on-site inspections, is there anything else you'd like to inquiry to note at this stage?
We've also spent 2 full days looking at learning for ourselves, because I think that's also important. Some of the things we did well, we think we could do better. And there's things like some of the strategic meetings we attended, we could do better in terms of ensuring continuity of representation from ourselves, and indeed recording and retention of what is discussed in a central repository. So there's a lot of learning for ourselves, and there's a lot of learning that I've outlined as best I can in the statement for the sector, but we can't forget the learning for ourselves as well.
Thank you very much, Mr. Mitchell. Thank you, my lady. I have no further questions.
Thank you, Mr. Beach. Ms. Mitchell. Ms. Mitchell's over here.
Mr Mitchell, I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved. I'm obliged to my learned friend Mr Beach, who has already covered a number of issues, particularly in relation to the evidence given by Mr McCaskill to this inquiry. In your statement, you advised that the Care Inspectorate had no involvement in the discharge of individuals from hospitals to a care setting. As a strategic organisation that advises on the impact of policy, what, if any, advice did the Care Inspectorate give on the impact of this policy to care homes?
The issue, as I understood it, came to light iteratively during the pandemic in terms of the discharge that, from individuals in hospital to care homes, and we saw the impact of that through the increased number of deaths. Our role, we don't have a role in the individual decisions for discharge. That's first and foremost a clinical decision by the GP or consultant. They do liaise with social work services, which are the domain of the Health and Social Care Partnership, and that's primarily to assess the needs of the individual upon discharge. I think one of the difficulties that I've already alluded to was the unavailability in many cases of domiciliary care, care at home, or a care home place. But those individual decisions are not ones that the Care Inspectorate are involved in.
Indeed, and I understand that. That was why it was prefaced in my question. But what I was looking at is asking whether or not the Care Inspectorate gave policy advice to care homes.
There is general admissions guidance to care homes, and it's made very clear to care homes that they should only take on residents, admit residents whom they have the ability to provide care for. So, for example, if they don't have nursing care, they shouldn't obviously take on an individual who requires nursing care on a 24-hour basis. But in terms of discharge from hospital, it's entirely the responsibility of the care home, the individual care home, to decide whether they can meet the needs of the individual upon discharge and upon admission to the care home. But beyond the general advice, we didn't give any particular advice, nor were we asked to during the pandemic at that particular period.
Well, the duty to ensure that the safety and well-being of all persons who are eligible to use a care service are to be protected and enhanced is the role of the Care Inspectorate. Was the discharge of untested patients from hospitals to care homes consistent with ensuring the safety, protection and well-being of people using care home care was paramount?
We understood on a daily. We understood that in UK, throughout UK, in Scotland and England, we heard daily that the decisions that Scottish Government and indeed UK Government were taking were based on the best clinical advice and guidance. That was clinical advice and guidance far in excess of what we ourselves would have access to. So our assumptions when decisions were being made by government, particularly those where we weren't consulted, was that they had access to the advice, the best clinical advice, and that they took the decisions they took on that basis. If we had been made aware of such a policy decision being made, we might have given a view, although it's difficult, if I'm being honest, to see how we would have given a view against the best clinical advice that government said they had on a daily basis.
Given that the statutory duty was on you, should you have been in the room when these questions were being asked and answered? Because at the end of the day, it's the Care Inspectorate jobs to ensure the safety and well-being of persons using care.
The primary responsibility for the providing care is the care service itself. The Policing Partnership and Scotland Health and Social Care Partnership have a duty of care. Our job is to provide independent assurance of the quality of that care and the safety and protection in the service. So again, it's not a decision we were involved in. There were a number of decisions we might have expected to have been asked about. I know and I understand that in England our colleagues were asked specifically for their opinion. In Scotland we were not.
So if going forward in terms of recommendations, ought you to be involved in that process and ask those questions about particular implementations of policy?
I think based on what we know now as opposed to what we knew then, I think we would certainly expect to be involved in such a decision in the future.
Moving on, in your evidence that you said you required the Director of Public Health agreement for visits in March and April of 2020. Was the requiring of this agreement by the Director of Public Health consistent with the discharge of your statutory duty as the Care Inspectorate?
It was very clear to us that we were not allowed to act unilaterally. That was a decision that was made very clear following the deep dive that was chaired by the First Minister. In terms of our responsibilities, we have responsibilities, but it's a very difficult decision to go against the advice of Public Health Scotland, who are the experts in infection prevention and control. We did, as I said earlier, maintain a policy position reserving the right to do so because we thought that was important, but we never actually exercised that.
So ultimately the responsibility of whether or not to enter the home and to inspect it fell to the Care Inspectorate, not to the Director of Public Health.
We have powers of entry to a care home at all times in Scotland, and those are legally enforceable. But the strong advice we had from Public Health Scotland and individual directors of public health was not to do that. We reserved the right to go against that, and indeed I was prepared to do that on the 3rd of May, but managed to get that advice. But that was the closest I got to going against the advice, was in respect of the 3rd of May inspection that we talked about.
Yes, and we covered that in your evidence in chief. I wonder then if I could move on to another issue, and that is Mr McCaskill, a final issue that he raised. In his statement, Mr McCaskill described members of the care home staff as reporting a sense of clinical abandonment, with difficulties in accessing GPs or GPs refusing to attend care homes. First of all, he said that it appeared that there was a presumption against external visits by GPs. Was the Care Home Inspectorate firstly aware of this issue?
I think this was the inconsistent response that resulted from the Cabinet Secretary's direction of the 17th of May. It was applied inconsistently, and as the subsequent clarification in the December of that year confirmed, there was an inconsistent approach resulting in what you've just described. In some areas, that clinical support from the community, from whether that be allied health professionals or indeed public health nurses, did not take place, but in other areas it did take place.
What was the Care Inspectorate's role in ensuring that such a policy, if it was being applied, wasn't applied? I.e., should the Care Inspectorate have done something as soon as it became aware of it?
So when we did find services that weren't getting that support, because by that time, remember, we were out inspecting again from the 4th of May, where we did find that support lacking, we escalated it to the Health and Social Care Partnership to ensure that it was put in place. And indeed, the government were aware of that inconsistency and clarified that. We reported also when we found failings, we briefed government on those significant failings as soon as we identified them, and that enabled the government to liaise with the relevant health and social care partnership through the office of the Chief Nursing Officer's Directorate in Scottish Government. So that was how we fulfilled our role going forward.
And you explained about that from the 4th of May, but what I'm talking about is the period of time earlier than that as well. What about the period of time before the 4th of May? Were you aware that GPs weren't going in and visiting?
We weren't aware of that prior to the 4th of May, no.
My lady, those are our questions.
Thank you very much, Ms Mitchell. Ms Morris. Ms Morris is just there.
Thank you, my lady. Mr Mitchell, I ask questions on behalf of the COVID bereaved Families for Justice UK. Just to return briefly to the topic of the discharge of untested patients from hospital to care homes, please. In your witness statement, you refer to an answer in Scottish Parliament by the former First Minister, Nicola Sturgeon, on the 27th of May, in which she admitted that patients should not have been discharged without testing. And she claimed, quote, the Care Inspectorate ensures that any concerns about care homes are considered. You comment that this was factually incorrect and open to misinterpretation. Can I ask you briefly to expand on what you mean by that? And then my second question is to whether that's another example of the Scottish Government not understanding properly the roles and responsibilities of the Inspectorate.
Yes, I suppose the statement that you've just read out I thought was rather odd, because the first half, as I recall, was about saying that the individuals should not have been discharged from hospital into a care home without negative tests. And the reference to the Care Inspectorate didn't make any sense to me in that context, because obviously I've outlined what our responsibilities were in that respect. I thought it was also odd because the guidance at that time, which was quickly amended, was that they didn't need a test. But of course we know now that the guidance was amended to require 2 negative tests before discharge. So I thought it was rather odd, and if I'm being honest, the statement about the Care Inspectorate didn't seem to join with the previous sentences.
Because you weren't involved in the decisions.
We weren't involved in the decisions, and it just seemed ambiguous.
But was it another example of the Scottish Government not properly understanding the role of the Inspectorate in this particular policy context?
Perhaps in this, I wouldn't like to say that broadly about everything, but in this particular context it seemed to be unclear what our role was in terms of discharge arrangements from hospital.
Thank you. Those are my questions. Thank you, my lady.
Thank you, Ms Morris. Mr Straw. Mr Straw is over there.
Thank you, my lady. Mr Mitchell, I represent John's campaign, the Patients Association and Care Rights UK. In your statement, you refer to Anne's Law, which gives people who live in adult care homes a right at all times to visits and support from those who are important to them. You indicate that the Care Inspectorate supports this. Could you explain, please, why Anne's Law is important and why your Inspectorate supports it?
Yes, we started to express concerns about visiting to care homes as early as the April of 2020, because we were concerned about the essential visits. Now, the essential visits, my understanding of that is that those were focused on individuals in care homes receiving end-of-life care and those in serious distress, perhaps living with dementia. And even although those were allowed, they weren't always happening when they should have been happening. And we started to, through one of my colleagues, particularly Marie Patterson, we started to share those concerns at some of the strategic meetings we attended. And we really were quite focused on that. So the individual behind Anne's Law was an individual who was recounting her experiences with her own mother, I think it was. And that was very powerful in galvanising support. And we tried to play a part in ensuring that visits were able to take place, but there was some resistance, it's fair to say, from Directors of Public Health. As we moved through the pandemic towards the May, there was even then some disagreements amongst directors of public health, some who were more in favour of visiting than others, but it was a significant issue, and I'm pleased to say that we, with some government funding, we were able to support in an interim way the visiting arrangements until the recent passing of the Care Act that allows the visiting now requires the visiting to be allowed. And I think that in Scotland it largely addresses the issues that arose during the pandemic.
I think Anne's Law was put forward by Natasha Hamilton, whose mother Anne was living in a care home during the pandemic. And she had dementia but was prevented from receiving visits by family carers for an extended period. And that led to a serious decline in her health and death. Is that right?
I couldn't comment on a particular case, but we certainly know that even at the point where window and garden visits were allowed, as we progressed through the pandemic towards the end of 2020, there was some freeing up of visiting restrictions. But even then, not all care homes were complying with that, and indeed some directors of public health were more robust in their approach to restricting visiting than others. And it was only towards the end of that year that things were starting to ease up. But just as they were starting to ease up, we had the second wave of the pandemic towards the Christmas, and that set us back again, where there were significant problems with some relatives accessing or having their visiting rights, respected.
And at least within your inspectorate, in light of this case and others like it, is there now a recognition that denying visits to essential carers can have severe consequences for people like Anne?
I think there's no doubt that there was significant distress with individuals who were not able to see their loved ones, and indeed the loved ones who were not able to see those that were in care homes. And that clearly has an impact on individuals. And that's something that I think the Scottish Government, as I say, have now addressed with the Act that's just waiting Royal Assent.
Okay. I think that's my time, so thank you very much.
Thank you, Mr Straw. Ms Beattie. Ms Beattie's over there.
Mr Mitchell, I ask questions on behalf of disabled people's organisations, and I have some questions about DNA CPR. In early 2020, there were reports, including in the media, of DNA CPR notices being misused and concerns about their blanket use. And Dr McCaskill, who's been mentioned quite a lot already this morning, says Scottish Care received reports from care home members that they'd been sent packs of blank DNA CPR forms without any previous discussion having taken place. Inclusion Scotland heard accounts of DNA CPR notices being placed on the records of disabled people and care users without notice or consent. So my question is, what steps did the Care Inspectorate take to investigate those publicly available concerns and reports that DNA CPR notices were being misused and had been inappropriately applied to disabled people and to care recipients?
We were not aware and never aware of any blanket policy of the kind you describe, although I do recall there were some references in the media to something of that nature. In terms of our role, even as far back as the first parliamentary report we produced on the 10th of June, we would routinely look at care plans, personal plans and risk assessments of individuals in care homes. We saw good examples of individual care plans, including anticipatory care plans, and we saw some poorer examples that were not updated appropriately, and those were outlined, and as I say, I'm sure in either our first or second parliamentary report there's mention of that, and in a number of successive parliamentary reports. So where we found plans that were not of our required standard, then we referred that and we referred that to the partnership. But as I say, we were not, as far as I'm concerned, DNA CPR means exactly that. It doesn't mean you're not entitled to other treatments. So again, just in summary, we were not aware of such a policy. We never received, as far as I'm aware, a complaint to that effect. although we did hear references to something of that nature in the media. But as I say, we looked at care plans routinely and risk assessments, and where there was good practice, we acknowledged it, and where there was individual failings, we identified that and shared that with those to ensure that the remedies were put in place.
So, Mr Mitchell, do I understand your answer to be that as part of your regular work, if you saw something that concerned DNA CPR in a C plan, in a care plan, you may pick that up, but that there was no investigation specifically into those reports and concerns that started in early 2020 about the specific use of DNA CPR in the pandemic context?
No investigation by us, because I certainly was not aware of any specific allegation being made, although I am aware that round about the time it was raised, I can't remember if it was in the media, I think Scottish Government put out guidance clarifying their expectations around anticipatory care plans and the conversations that should always take place involving the individuals and their families, particularly if they lack capacity. So clearly there was something that prompted Scottish Government to put out clarification guidance, but nothing that came directly to us that would have caused us to investigate in the way that you described.
I think the letters that you may be referring to were sent to GPs, but not to the care sector. So given the Care Inspectorate's role for the care sector and for that end of the equation, if I can put it that way, would it have been of assistance for the Care Inspectorate to have done something, for example, such as what the CQC did in England, to carry out a review and an investigation into whether these practices were happening in the care sector?
I don't think we had information of a sufficient nature to cause us to investigate. Our expectations around care planning and anticipatory care plans are clearly identified in our inspection frameworks, our quality frameworks, and there was nothing that I recall that we got that wanted us to do anything over and above what we did was by looking at individual care plans. It may have been that if there was guidance, we played a huge role on behalf of government through our reform system. We had a provider update every week, and we would often share guidance that government asked us to share. Whether there was anything around that we shared at the time, I'm not sure, but there was certainly nothing of that nature came to us officially that was prompting us to think about an investigation.
Thank you, my lady.
Thank you, Ms Beattie. That completes the questions that we have for you, Mr Mitchell. Thank you very much indeed for your help. And as I've said to some of your colleagues, I hope you didn't have to prepare the whole of this statement. So thank you to any colleagues that helped you to prepare it, and safe journey back to Scotland.
Thank you, my lady. Thank you.
My lady, the next witness is Professor Fu-Meng Khaw.
Thank you.
If you could repeat after me, please. I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give shall be the truth,
the whole truth,
and nothing but the truth.
Thank
you, please.
Hope we haven't kept you waiting, Professor.
Not at all.
Ms Paisley.
Professor, thank you for attending the inquiry today and for providing your statement to this module dated the 28th of May 2025. Professor, you are National Director of Health Protection and Screening Services and Executive Medical Director of Public Health Wales, having commenced this role on the 1st of June 2021. Is that correct?
Good afternoon. Yes, that's correct.
Good afternoon. By way of brief background, you qualified as a surgeon and spent some time working as a consultant in communicable disease control with the Health Protection Agency. You then took up appointment as Director of Public Health for 2 local authority areas in England. In 2013, you became the East Midlands Centre Director for Public Health England. and in 2020 and 2021, you were involved in Public Health England's response to the pandemic in a number of national roles. Is that right?
That is correct.
Public Health Wales is an NHS trust, having been established in 2009. It has a number of assigned functions to protect and improve health and well-being and to reduce inequalities for the people of Wales. Amongst other things, it is a provider of public health-related specialist advice to the Welsh Government and its ministers, and that's something it did over the pandemic, is that right?
That is correct.
Can I begin by asking you, please, at paragraph 152 of your statement, you explain in early January 2020, Public Health Wales joined the Public Health England-led COVID-19 incident management team, and that was together with representatives from both Scotland and Northern Ireland as well. Now, in preparation of this statement, can you confirm if and when it was observed in those interactions that this new virus may have serious consequences for the adult social care sector?
So I'm aware very early on in January there was a meeting held that included the devolved administrations on highlighting the potential that this virus would spread globally. And throughout January we attended the daily incident management team meetings that then Public Health England had organised. And we took notes of those meetings and fed those back internally within Public Health Wales, and where relevant we also shared that with Welsh Government.
You explain that Public Health Wales has a business-as-usual call centre.
Sorry, just before you go on, I'm so sorry to interrupt, Ms. Paisley. Ms. Paisley's question was, when did you observe that the new virus would have a serious consequence to the adult social care sector? I think what you addressed is when you became aware it could become a pandemic.
So at the time, the focus was very much on the people who were most at risk, i.e. those returning from high-risk areas. And all the cases up till the 1st of March were imported cases from abroad. And the 1st of March was when, the sense of community transmission became apparent in the UK. So I would take it as read that there was always a risk of community transmission in the UK, but it wasn't until the 1st of March when it was confirmed. So as a result, an extension of that, because of the vulnerability of people in care homes, we had always assumed that this would be a problem in the care sector.
So it would be fair to say quite early on?
From the outset.
From the outset, thank you. Now, you explained that Public Health Wales has a business-as-usual call centre, and that's called Aware. That receives notifications of all communicable diseases, can be contacted by NHS professionals for advice. However, it's right that that was not routinely used as a route for care homes to contact Public Health Wales.
So the Aware team would receive notifications of infectious diseases. This is a statutory requirement, and usually it would be done under the proper officer regulations through notification from clinicians. However, if care homes were experiencing incidents such as influenza, they would also seek advice and report these incidents to us, and we would support them.
So they could contact through that team?
Indeed.
As a result of the number of queries received by the call centre, it's right to say that it became overwhelmed, and so a national contact centre was established to focus specifically on COVID-19. Can you help us with when that was established, please?
So at around the end of February, we think around the 25th of February, a report was made to the Gold response team in Public Health Wales from our health protection team who oversaw the Aware service, indicating that there were many, many more queries coming through from across Wales into the team, and it needed further capacity. So as a result of that, very shortly afterwards, in late February, the National Contact Centre was established.
A decision was then taken to formally establish the enclosed settings cell. I think that was the 25th of March 2020, so around a month later. Is that date correct?
That is correct. That was the formal establishment of the enclosed setting cell. But in practice, following the first notification of an incident of COVID in a care home on the 15th of March, shortly after that, we recognised that there were increasing calls from the care sector that we had to manage as a separate entity. So work had already been done to establish the shadow enclosed setting cell.
Are you able to give an idea of how many calls Public Health Wales would receive in non-pandemic times from care homes as against the numbers you were beginning to receive in March 2020?
I don't have that information to hand, but we can provide that later.
Would it be fair to say it's significantly more?
It was significantly more, which is one of the reasons why we established a dedicated enclosed setting cell. And just to give you an idea, throughout the 90 days in which it was operational, there were over 17,000 actions taken, recorded in our case management system.
Practically speaking then, what was the purpose of the enclosed setting cell? Was it to provide advice or was it something else?
So there were four key purposes for the enclosed setting cell. One was around policy and strategy and providing advice to decision makers on that. The second was to receive notifications of incidents of cases or outbreaks in a care home setting. The third was to provide advice directly to care homes. And the fourth was to support the management of outbreaks and incidents in care homes.
Were you receiving any concerns from providers at that point? And if so, can you give an overview in those early days, so March 2020, what sorts of concerns were being raised?
So this was a difficult time, shortly after the 15th of March, when we received the first notification, we started producing regular surveillance reports of the care home sector. So from the 20th of March, our daily reports included summaries of care home incidents and outbreaks. And most of the inquiries, because of the nature of our organisation and the historical support we would give, would be about how we ensured that the best infection prevention and control advice was given and adhered to in a social care setting. And we recognise that in care home settings, the facilities are very different to a hospital setting, and the ability to maintain infection prevention control would be difficult by virtue of the nature of the residents. For example, someone with dementia, it might be very difficult to retain them in their room if isolation was required. So we dealt with the practical issues that care homes were facing and provided advice as required.
Specifically in respect of concerns that providers may have been raising, was there a mechanism by which Public Health Wales could raise those concerns with the Welsh Government to factor into Welsh Government decision making?
So we had regular contact with Welsh Government policy leads, the Chief Medical Officer, and also the Deputy Director General, who was overseeing the social care policy area. And our communications with them were regular, both in terms of physical meetings and also by emails. And where appropriate, we would exchange information about the concerns that we were hearing about from care homes. And of course, they also had mechanisms directly to hear from the care sector and through the regulator, Care Inspectorate Wales as well.
Now, before we come on to infection prevention and control, staying just with these structures, were these structures an effective way to manage calls from the sector, in your opinion?
We think that by providing a dedicated cell with a dedicated number, that improved the ability for the care sector to reach us and know that there's a dedicated team who's familiar with the cases. In the end, after the 90 days of the existence of the enclosed setting cell, we actually communicated with 3/5 of the care homes registered with Care Inspectorate Wales across Wales.
Now, I understand that in April 2020, the enclosed setting cell worked with local environmental health teams and local authorities across Wales to develop and introduce a standard operating procedure for proactive contact with the aim of preventing COVID-19 entering all settings that did not have an ongoing incident. Can you provide a brief overview of that standard operating procedure, please?
So this was a time of immense change, that we had to work in a different way with our key agencies across the health system, including our environmental health officer colleagues in the local government. And typically, they would be involved in food poisoning outbreaks. But for COVID, it was a different area of involvement. For example, for other respiratory infections, we wouldn't involve environmental health officers in managing influenza outbreaks, for instance. So this was a new area of work. So by developing a standard operating procedure, we were able to clarify roles and responsibilities, which at the time of a significant change was very important.
In June 2020, Public Health Wales then transferred information on care home incidents to regional test, trace and protect teams. So did all functions then transfer over at that point? And if so, why?
So this was part of the Public Health Protection Response Plan that we proposed to Welsh Government on the 4th of May, following a request that they made for us to develop this plan on the 22nd of April. And the implementation of this would be to enable local resource to deal with local incidents, including those in care homes.
Did Public Health Wales, however, continue to support those local teams?
We did. And we did it through our normal response plans, through the roles and responsibilities recognised in the standard operating procedure. And we were able to focus on providing advice for guidance, developing guidance, advice on policy decisions, and also, very importantly at the time, focus on surveillance.
In the event of a future pandemic that may have severe consequences for care homes and the sector more generally, do you think the enclosed setting cell and the structures that we've just looked at would have a part to play?
We think it would. You know, we did an evaluation of this at the end in May 2020, and the evaluation was very positive, including positive feedback from the care sector.
Are there any specific lessons you would draw to the attention of the inquiry about the operation of those structures?
So I think the enclosed setting cells had a wide remit, including direct response to inquiries and managing incidents and outbreaks, and the receipt of notifications of infectious diseases. And I think in future we would separate out the guidance function to form a dedicated guidance cell. In fact, throughout the pandemic, we learned from that and established an internal guidance subgroup on the 1st of June following the dissolution of the enclosed setting cell.
Thank you, Professor, and that's something we will touch upon later in your evidence. Can I please move on then to infection prevention and control, which we briefly mentioned. Now, you've said that one of the roles was to provide advice on infection prevention and control measures, including isolation. You explain the initial guidance was in line with the 2016 guidance. Can you help us? How long was that advice relied upon before there was tailored advice specifically relating to COVID-19?
So we looked to respond to COVID initially as we would any other respiratory infection, given the common denominator around the transmission routes that we knew at the time. But when guidance was being produced in England by UK government and published by PHE, DHSC, we felt we had to align with that guidance, because that was published on the gov.uk website, which had was accessed by everyone. So we wanted to be consistent. So when we published the first information sheet on the 24th of March, we made sure that we provided links to the extent guidance that was specific for the care sector at that time.
When you say we felt we had to align, was it appropriate to align clinically?
It was, because we were confident that the evidence and the scientific evidence was being reviewed, and we were part of that review through the structures that Public Health England put in place through the incident management teams. And more latterly, the establishment of the UK IPC cell had involvement from all the devolved nations. And in fact, the chair of the UK IPC cell, Dr. Ilaria Davies, was working in Public Health Wales at the time.
So to what extent was IPC guidance issued to care homes in Wales tailored specifically to Wales, if at all?
We were always aligned with the UK IPC guidance, and our interpretation of that guidance for Wales was around contact numbers and also local risk assessments. And when it came to very detailed guidance like risk assessments for visiting, for example, we did produce bespoke guidance within Wales.
To what extent, in your view, is bespoke guidance necessary for different nations of the UK?
The systems are different across the UK. The structures are different. So it is very important that local guidance is available that reflects that system. So there are fundamental differences in the way that healthcare is delivered in Wales in terms of the structures around them. So health boards have a different role to hospital trusts in England, for instance.
Focusing on the care sector, the inquiry heard evidence yesterday from Care Inspectorate Wales that care homes in Wales tend to be quite small, perhaps in contrast. Did Public Health Wales consider the physical infrastructure of the smaller care homes in Wales, and specifically whether that may limit their ability to ensure ventilation, for example?
We were familiar with the care sector's constraints in some of the care home environments, and the advice that we provided was always taking those local factors into account. So whenever a care home contacted us for advice, we would become familiar with some of the constraints and challenges they were facing. And we provided practical advice on how you might, under those circumstances, maintain infection prevention and control.
Would any improvements required to ventilation in care homes be something that Public Health Wales would advise on?
That's not something we would routinely advise on, and we would look to our specialist estates colleagues to provide that specialist advice.
When you say your specialist estates colleagues, who would that be?
That wouldn't be within Public Health Wales.
Which body would that be within?
I think it's within the shared services construct in Wales.
Can I move on to another topic then, data, please? Did Public Health Wales have access to definitive data regarding how many people were in receipt of care in the adult social care sector at the outset of the pandemic, so February, March time?
That's not something we routinely collect, because our prime purpose is to collect information on incidents and outbreaks and cases of infectious disease as a statutory requirement. The denominator of who is in receipt of care is not something we have ready access to.
Are you aware if it did exist at the time?
We were aware, clearly, of regulators and responsible persons for adult social care, but we wouldn't know where to look for the data around the numbers of people in receipt of care.
Do you think it would have helped Public Health Wales if it had known where to look and if it had access to the numbers of people in care?
I think if we knew the denominator, and that is the total number of people in receipt of care, it would have helped us understand the rates of infection in adult social care, for instance, when we were able to report on the numbers of cases in receipt of care.
Your statement touches on data issues in a number of places. Generally speaking, what were the main deficiencies that Public Health Wales observed, and what steps were taken to improve access over the course of the pandemic, particularly with a focus on the adult social care sector?
Yeah, thank you. So if I start by looking at the process of data collection, we rely on people to report to us incidents and outbreaks of cases of infectious diseases. We also have a laboratory system that records the numbers of people diagnosed with a particular infectious disease. However, we rely on the information in the request form to be able to associate that individual with an address or a particular characteristic, whether it's age or gender. Now, we don't have a tick box that says, are you in a care home? So that made it difficult for us to link the request and therefore the result of that test to whether a person was in the care home. And we did an exercise to look at linking by asking Care Inspectorate Wales for their list of regulated care homes, and by discerning their postcodes we were able to link the number of people who had been affected that way. But having done that, we recognized there were still gaps in the data collection that meant that whether it was an error in the postcodes, we weren't able to link all the cases.
There was a particular issue, I think, with deaths data and the conflicting sources. Can you provide an overview of that, please?
So we knew it was important to monitor the trends of deaths from COVID over time and across high-risk settings, particularly in hospitals and care homes, and worked with Digital Healthcare Wales, DHCW, to put in a process which was an e-form, electronic form, that people could use to notify us of deaths. This form was not mandatory, but the then Director General for Health and Social Care wrote out to all health boards asking them to use this form from the 23rd of April. Up to then, the notification of deaths from the care sector was through our enclosed setting cell. People would report it and we would record it and put it into our surveillance systems.
Is there any recommendation to the inquiry then about the collection of death data in the care sector that you would recommend for future pandemics?
So I think, particularly in the early stages where monitoring was critically important, to look at how bad an infectious disease might be, we need a single point of data collection. Now, for deaths data, the Office of National Statistics ultimately is the most comprehensive source of data collection through the regulated and mandatory processes, but that has a time lag of a few weeks. And the balance is always between timeliness and comprehensiveness. So surveillance helps with the timeliness, but we always recognize that it's not always going to be comprehensive. So we would see that there's a single point of registration of deaths from an infectious disease of concern, and that and public health agencies with that responsibility should be the single point of reference for that.
And just one final question on data, please. I think you acknowledged that there was limited surveillance of domiciliary care and unpaid care. Is that something that you would recommend should be collected in the future? And if so, who would have responsibility for that?
I think we would wrap this up in our overall responsibility around surveillance. Our ability to cut the data or report on the data according to the area of interest is very much dependent on how that data is coded. Now, if there was a field that said this person is in receipt of domiciliary care, we could easily capture that. But the difficulty is that in the request for a test, those fields are often not available to us. So we need to rely on linking that data, and that relies on working with partner agencies who may hold that data.
Going to move now, please, if I can, onto the chronology. In February 2020, guidance was produced by Public Health England Was Public Health Wales asked to review that guidance? So this was the 25th of February social or community care and residential settings guidance.
So this guidance was mentioned in draft form at one of the PHE incident management team meetings. I believe it was the 19th of February. Our team made some suggested changes, but because they were largely to reflect the Wales context, those changes weren't taken into account. Nevertheless, we also shared that draft guidance with Welsh Government to ask whether we needed to produce a Welsh version of the guidance. And I believe Welsh Government took that advice and on the 6th of March produced guidance similar to that produced by Public Health England for Wales.
If we can move on to March 2020 then, and just a few more questions before we break. You explain at paragraph 189, Public Health Wales had no record of being asked for advice in relation to the development of policy and guidance with regard to the Welsh Government's decision on the 13th of March to discharge asymptomatic patients to care homes without a COVID-19 test. Is that something Public Health Wales would expect to have been consulted on?
We would expect to, be asked to give advice on key policy decisions, such as the one you've mentioned.
As a public health expert yourself, with your experience, if you had been consulted about that policy at that time in Wales, what would your advice have been?
Specifically in relation to testing for hospital discharges, yes. I think our view at the time was, we had only just introduced the SARS-CoV-2 assay in our laboratories. That was approved by the Chief Medical Officer on the 7th of February. And at the time, the assays that were available were very early in the development of the testing. So we were still trying to understand how the test would behave and what the sensitivity and specificity of the test is. So we weren't sure about what a negative test would actually mean. So we know over time that settled at around 70% sensitivity, which is the ability of the test to detect a true positive. So if it's high, then it's detecting a lot of true positives. But if it's low, then the number of false negatives are then very high. So a negative test result didn't necessarily mean that the individual wasn't infected.
Thank you. And I think we'll come to look more at the advice Public Health Wales gave. But, my lady, I wonder if that might be an appropriate moment.
Sorry we have to break off for lunch, but we shall finish you this afternoon, Professor, I promise. 2 o'clock, please.
All rise.